Welcome. My name is Dr. Jean Elwing, and I'm a professor of medicine and the director of the Pulmonary Hypertension Program at the University of Cincinnati. I'm going to be talking to you about modern diagnostic approaches in PAH. So what is the new definition of PAH and how did it arise? How did we get here? Well, it was recently published in 2018 that borderline pressure between 20.6 and 24.9 was associated with decreased exercise capacity, as evidenced by the 6-minute walk test declining and the peak VO2 declining, as well as increased mortality. And you can see here the mortality in the patients with normal pulmonary pressures are much lower than those with pulmonary hypertension, but those borderline patients have increased mortality over normal pressures. So something that really caused us to step back and think about our definition. So where did we get this normal from? The data is actually from more than 1,000 normal subjects, followed in more than 45 studies, and they looked at what the normal pressures were at rest, and they were 14 plus or minus 3.3. It did not seem to be influenced by gender or ethnicity, but slightly increased by age and posture. And as I mentioned, a mean PA pressure more than 2 standard deviations above that normal is 20, and that is now considered our cutoff for the definition of pulmonary hypertension. But we also included to have a true definition of precapillary disease, or what fits in pulmonary arterial hypertension. You must also have low left-sided filling pressures by a normal wedge and evidence of pulmonary vascular change by high pulmonary vascular resistance. So again, new definitions, changes. Many more people will meet criteria for pulmonary hypertension now than they did in 2017. That's a mean pressure of more than 20 at rest. As I mentioned, it doesn't define disease, but it is consistent with an abnormal PA pressure. And the new definition of precapillary pulmonary hypertension includes that PA pressure more than 20 with a wedge of 15 or less and a PVR of 3 or more. So how can we apply this to our current patients? We don't have any group of patients that have been treated in this range, but maybe this will prompt us to look for more effective therapies in this group. We know that these patients have decreased exercise tolerance and increased mortality. And also in our CTEPH patients, maybe we could intervene earlier. But of course, we need to study this and better understand the implications.